Well, happy Friday. Facebook Live, 3 o'clock on COVID update. I don't know about you all, but it's been a long, busy week. I'm looking forward to the weekend. I hope everyone else is. I hope you're still social distancing. Okay, data. Global cases. So 990,000 yesterday, up to 1,070,000 now. So still growing. 57,000 worldwide deaths, up from 51,000 yesterday. US has climbed again, 265,000 cases right now. What's interesting to note, though, and I really do want to make this point, is if we look back to March 31st, for each of the subsequent days, it's been about a 30,000 case increase. And again, what we don't know, so it's been pretty stable, not this rapidly rising escalation in the same way that we've been worried about it. And what's a little bit unclear is whether or not that's due to lack of testing, only testing the hospitalized patients because we still don't have widespread testing. And we're now understanding that maybe 25 or 30% of people who are infected have a completely asymptomatic infection. But I think it's a little bit of data to suggest that what we're doing with social distancing is really working and why we need to continue doing it. The US deaths climbed from 6,000 to 6,800, so a big jump. What you'll see, though, is the majority of those cases the deaths are in New York. Italy jumped from 115,000 to 120,000. Spain jumped from 110 to 118, so they're right neck and neck right now. Italy deaths are at 14,600, just a huge number, and Spain deaths are at 11,000. So if we go back to the States again, 265,000 cases in the US, 6,800 deaths. In New York alone, and I really can't emphasize what bad shape New York is in, 103,000 cases, so that's up 10,000 cases from yesterday. 3,000 deaths in New York. And again, if we look at what's the next closest state, it's New Jersey, which is at about 30,000 now. California, 11,000. Michigan, 11,000. And Florida had a big jump up to 9,600. So again, big difference between New York and any state that comes next. In New York City alone, so New York has 103,000 cases. New York City is at 53,000 cases. So again, still more than half. And again, the deaths in New York City are 1,600. So again, a large percentage of the deaths, more than 50% of the deaths in New York. Our Ohio numbers, so we went from 2,900 yesterday to 3,300 today, so about a 400 case increase. That's a little bit more than the last prior days where it was about a 300 case increase. Our deaths, again, went up from 81 to 91, so 10 cases. Our hospitalizations went up from 802 to 900, so that's a big jump. And our ICU cases went from 260 to 288 across the state. So again, we're still really looking at that hospitalization rate of not quite 30% and an ICU percentage of about 9%. So again, still we're seeing very sick patients requiring hospitalization and many of them requiring ventilation. That IHME data that I told you about, which I think is terrific, again, I really encourage you to look at that IHME.com website. The data for US, New York, Florida, Ohio looks relatively the same. So the big takeaway is it looks like we will still have a need of about 32,000 ventilators in the US. It looks like we'll still have an ICU shortage of about 20,000 beds. And a total bed shortage of about 88,000 beds. And the total death rate is still estimated on this modeling to be about 100,000 people across the US up until August. I did just pull Michigan data just to look at that because we haven't really talked about that before. They look like they are going to peak about the same date as New York, so April 9th. They're looking at a need of 15,000 hospital beds, and it looks like in Michigan they're going to be short about 5,000. They look like they're going to have an ICU shortage of about 1,700 hospital beds, and their total death rate in Michigan looks to be about 3,200 cases. So, what's new in the news today? So I think the big thing is Dr. Fauci really came out very strongly in the last 24 hours, really suggesting that he believes that all states need to have the stay-at-home policy, which, again, I think I've been talking about for weeks here now. It really never made any sense not to have a federally mandated stay-at-home policy because, again, we saw this in Italy. You can't quarantine one specific area or one specific state and expect that the stay-at-home policies are going to have substantial impact. And so, again, I wish that this had happened early. We are at the majority of states. I believe that there's 10 states still that have not issued a stay-at-home guidance yet. So hopefully that's still going to come because we need that still. But again, I think that's the first time and the strongest time I've heard Dr. Fauci say something. Some of the data that's continued to come out now, there's been, we've talked about this and I've kind of said no on earlier Facebooks about whether or not, you could have the virus in kind of just the air. We talked before about having it being spread with droplets, right? So that's the 6 feet rule, which is that droplets based on gravity go about 6 feet. And if you're beyond that, you really, when someone coughs or sneezes, you won't be exposed. And if there's droplets on a hard surface and you wash your hands, then you're not obviously touching your face, and so you're preventing infection that way. There's more data now that, at least in some cases, there can be airborne spread of the virus, which means, again, it can come from just breathing or talking, or in the case of the choir practice on the West Coast, where so many individuals were infected by singing. So this really translates into why there's this ongoing discussion, and probably will be CDC recommendations now, that everyone who's going out now and about, when we're not social distancing, and we still should be social distancing, should be wearing a mask, because if we have an asymptomatic infection, again, it goes back to we would be protecting others from putting those viral particles, either cough, laugh, sneeze, into droplets, or just by breathing into aerosolizing them. And so I do think with this, at least more clear data, that in some cases the virus can be airborne, that it makes sense now to start to think about having, all of us wearing masks when we're out. I think one of the things that's really been talked about on the media, though, is to understand that we don't want the public taking masks, the N95s or the surgical masks right now, away from healthcare workers who really need it, because we still are in short supply. Now, again, I keep hearing from President Trump that quickly we're going to have enough adequate masks and PPE. I haven't seen that yet, or don't know that yet. So at this point, the recommendation is really for individuals going out to use a bandana, a scarf, a shawl, something that's cloth, to cover your mouth and nose. And again, there's lots of great videos out there about how to make really cute handmade or home sewn masks, which I would consider doing. I was on my earlier Facebook today with Dr. Burkholz and suggested that I predict this is going to be the new designer look coming up. So masks developed. Some of the discouraging things that's come out today is really more data, again, about the death rate in patients who are put on ventilators. So, of course, we are talking, and we continue to talk about the need for ventilators, particularly in New York right now, but in other places that are key cities where the outbreak is so substantial, where we're going to need more ventilators. Part of the issue, and we've talked about this before, with what's happening with individuals, and it's about 5 to 10% of individuals who become infected get seriously ill and require ICU stay and may require a ventilator. It's because the pulmonary process that happens is related to very aggressive severe inflammation and developing a picture called ARDS. And ARDS is a condition where you have difficulty getting oxygen across the lung tissue. And so that's why these patients require mechanical ventilation, is because you're trying to push oxygen across their lungs into their bloodstream. The problem is this is a very different ARDS, and what's happening in patients who are really sick with coronavirus is different than pneumonia, when you need to be intubated. So when you have a bad pneumonia, as patients do, and need to be put on a ventilator, in general, it's a couple days. maybe 3 days, maybe 4 days, when antibiotics treat the infection, and again, then the need for supplemental oxygenation and kind of mechanical ventilation goes away. It turns around really quickly. The unfortunate thing, and we've known this from the Chinese data that I talked about early on in these Facebook posts, is that the people who require mechanical ventilation, they're in the hospital for a really long time. So they need the mechanical ventilation for a long period of time, 18 days, 22 days. In fact, that China study that I talked about in the beginning, 2 weeks ago probably now, was that in China, in the patients who made it out of the hospital from the ICU, the average duration of mechanical ventilation was 22 days. In the patients who died, the number of days was 18 days. So a long time to be on a ventilator. And, it's very serious in this situation when you actually get put on a ventilator. The news today came out of London. So this is kind of more recent than the Chinese data that I had, that in London, of 98 patients put on a ventilator in this small study, 65 out of the 98 died. So a very high percentage, 70 to 75%. In the small China data, it was 19 out of 22 patients that died. And so again, this is really the really important take home here, is that if you are a patient who becomes critically ill with COVID, your mortality rate is very high. And so again, it goes back to why this is so important that we do the social distancing. We need to protect everybody and prevent the infections from even happening. 100,000 patients dying of this is tragic, but without the social distancing, again, the numbers would be much, much higher. And so as we continue to get further into this, and we really look like we've got at a minimum 4 weeks, and probably more realistically 6 to 8 weeks of requirements to stay at home, this is the reason you have to keep reminding yourself, which is that this is a bad infection in a subgroup of patients that get this, and you just don't know if you're going to be in the subgroup of patients who, has an asymptomatic infection and does fine, or if you're someone who's going to be seriously ill. Okay, if you look at my Instagram post from earlier today, you will see I put out there a graph that I thought was really helpful just to talk about what's coming very soon, which is what's called ELISA testing, which is a way that we can test for antibodies. And so when I was on my mission trip in Africa this past summer, for example, we had a very quick, rapid ELISA test to detect HIV in the patients that we were seeing. A finger, a drop of blood, and a quick test, which would give us a result almost instantaneously, within minutes. What's out there now, and what's available, has been available in China and overseas, is a similar ELISA test to look for antibodies to the COVID virus. Now, what you have to remember is what we've been testing up until now using the nasal swabs, okay, so the one where you have to put it way far back in your nasal passageways, is to take secretions, and then we're doing an analysis to actually detect the virus itself, the viral particles, right? So that's not the antibodies. The antibodies are the body's response to the infection. And if you look on the graph that I put on the Instagram site, you will see that for most infections, the typical antibody response is you get an acute phase antibody response of IgM antibodies. And then as you get to long-term immunity, this is what vaccines do, you get IgG antibodies. And so in this circumstance, if we think now, remember we've talked that viral shedding in an infection starts several days before you get symptoms. And obviously if you're asymptomatic, starts at some point you don't even know. So maybe 5 days roughly prior to having any symptoms, and continues depending on the severity of your infection for probably 21 to 28 days after your symptoms. During this period of time, IgM antibodies start to go up at day 3, 4, 5. And so you'll see a peak of IgM, that's the acute antibodies when you're making them for the acute infection. And then later than that, day 7, 10, 12, you will start to have the presence of IgG antibodies, which are the antibodies that show that you've resolved your infection and you're going to have long-term immunity. Long-term, that's a question mark because we don't know exactly how long-term with this. But the ELISA test that's coming, and hopefully will be available soon, is able to detect quickly the presence of IgM and IgG antibodies. And so although it's not perfect for telling you if you have an acute infection or not, it can be really helpful, right? So if you have IgM antibodies, if we can detect them, it tells you that you are during the acute phase of the infection. If you have IgG antibodies, it tells you that you are beyond the infection. So, for example, if someone had no symptoms and we could detect that they had IgG antibodies, that would be great because we would know they would have some degree of protection, probably great protection against being infected again. And these would be the healthcare workers, if we could identify them, who we would want to have on the front lines because they would be safe. If you have a completely negative test, it doesn't tell you one way or the other, right? So if you have a negative test, it could mean one of two things: that you don't have the infection, you haven't been exposed, so you continue to be at risk, and that's why you should continue to have self-quarantining. Or it could mean you're very early in your infection, in the first days when you're just viral shedding, up until the first few days of infection when you haven't produced IgM antibodies yet. And so again, not a perfect test. It is coming. It would be used in addition in some circumstances to the test for the viral RNA itself. It has the advantage, though, of not requiring PPE for healthcare workers. So when healthcare workers are doing the nasal swabs for the virus, we have to wear the N95 masks and be protected because it can be aerosolized. This, with a drop of blood, is actually much safer. Nothing's being aerosolized. It's an instantaneous result as well. And so there's some advantages of this. And again, I believe that this will also, as a secondary type of testing, will become available relatively soon and will help us scale our efforts to have a better understanding of who's infected and who's not infected. So again, we can really come up with appropriate stay-at-home policies and guidelines about who can be out with a mask, without a mask. This will all evolve over the coming months, but more to come. It is great that this antibody test is coming. Okay, so let's see. You take what we hear on CNN, Fox, etc., and condense it to understandable and actionable insights. Oh, that was very nice. Thank you for that nice comment. I thought it was a question. When wearing the homemade masks, is it one and done, meaning when it needs to be washed immediately and between each use? So again, remember that these are for preventing you, if you're infected, from spraying the virus to other people. And so in reality, it doesn't really need to be washed for you. Now, the flip side, though, is that other people should not be handling that mask, right? Because again, if you are infectious in the same way, right, and someone else wore that mask, then you're exposing them. But for you as an individual, we are using it on you, and you can use it repeated to prevent transmission of viral particles to other people, so you can use it. If I take Advil for a typical headache, does this increase my risk of contracting COVID? Well, so let me tell you that we don't completely understand that. Again, if Tylenol works for you for that same headache and you can substitute that, I would tell you right now with the limited data, that's what I would recommend because it's just easy to do. If you have a condition or a headache that doesn't respond to Tylenol, which is often my headaches, and I will tell you I have taken some Advil in the last several weeks, I think it's okay because we just don't have 100% of data to say one way or the other. I think we're going to learn more very quickly, and right now we should all be, exercising caution. But again, there are circumstances where if you need to take an anti-inflammatory, I think it's okay. Besides having an underlying condition, are there any factors that can predict who will get critically ill with COVID versus people that have only mild symptoms? Well, this is the million-dollar research question, and we have to figure this out. We have been looking at clearly underlying conditions clearly play a part, but then looking at obviously certain medications that patients are on, like the specific blood pressure medications for hypertension, for example, as whether or not they're contributing. There's a little bit of data about blood type, but it's not very clear yet. And what blood type, I would suggest, means is kind of the same way it's a marker for a genetic type that makes someone more susceptible if and when it turns out to be the case that, for example, that blood type A positive is associated with a more severe infection. So think about it this way. This is like red-haired individuals have a higher likelihood of having skin cancer. It's not that the red hair causes the person to be higher risk for skin cancer. It's that the red hair is a marker of a genetic skin type and predisposition that makes skin cancer more common. And I believe that it'll turn out to be the same way with blood type if in fact we find an association. But I absolutely believe that this is the million-dollar research question, billion-dollar research question, is to be able to identify who are the individuals who are really the ones that are going to be in that category of 5% of people who need ventilator support and who have that very, very high mortality, because we've got to be able to identify those. And we, of course, have to be able to have testing and a vaccine, but we don't really understand it yet, but that is coming. You may have heard this is the time in medicine now where we're really looking at personalized medicine and really starting to do whole genome sequencing and pharmacogenomics to understand an individual patient and their susceptibility to certain diseases and an individual patient's response to certain medications. And as we have more and more understanding of this, and I'm sure they will be looking at the genetic profile of patients who did well with COVID, asymptomatic, and those who did poorly with COVID, because I'm sure that there will be something to that. And hopefully even more than genetic things that will identify markers, potentially in serum, for example, that we could use to help us stratify patients. What do we know about how long a person might be immune if they recover from the virus? So this also is an unknown question at this point, but we're hoping from some limited data that it will be long-term immunity if you've been infected. And why is there some data to suggest that? So if you think about influenza, flu, why do we have to get a flu vaccine every year? Well, that's because flu virus mutates, the influenza virus mutates every year. And so the virus that we are seeing in the 2019-2020 winter is a different virus than we saw the year prior, and is not going to be the same virus that we're going to see for influenza coming up in this year, because it very rapidly mutates. And so as individuals are developing the vaccine in the United States each year, they're looking at the genetic mutations that have been happening in the countries that come before us, right? As this is migrating globally. The good thing that they have seen so far with COVID is that it seems to be a very stable virus. It seems to not be mutating. So if you think about it, if you have one infection with one specific virus and you produce one group of antibodies against that virus and the virus doesn't change, those antibodies, if they hang around long enough, will confer long-term immunity. So one of the things that we have, for example, is hepatitis B vaccine. Once you're immunized with hepatitis B, you have an IgG antibody, and that lasts your lifetime. You don't have to be re-immunized with hepatitis B vaccine. That works. You will always be protected. The hope is now, although we don't know this, right, because this is a new virus, is that that will be the same case with coronavirus, that once we identify an individual as having positive IgG antibodies to COVID-19, that means that they will have long-term protective immunity. And it's the same thing we hope with being able to develop one vaccine that we give one time that confers long-term lifetime immunity. We don't know that 100% yet, and that again is coming, and we need more data to confirm that, but hopefully. A friend of mine has covered, and she maybe recovered, and she has very red eyes. Her doctor told her that that's the most lethal type. I am sorry to say that I don't know anything about that. Most lethal type of COVID, red eyes. I'm sorry, I don't know anything about that. I can't say. Is there any chance that this virus was in our country earlier? We had a positive test for flu B in December, and another family member got the same thing in January. It was definitely harder on the respiratory system than I had ever witnessed. So we're not 100% sure yet. This goes back to not having adequate testing, or even not having the antibody testing available yet, right? If we quickly get the antibody testing right now, and we go out and we test lots of people, and we see that there's lots of people who have IgG antibody already, that probably is going to mean that it's been around longer than we have known about, but we just haven't had that testing. Now, you're not the only person that has said. I've had several patients this winter who have had very bad viral illnesses that have been flu negative, flu A and B negative. And so the question has come up is whether or not that could have been COVID. And I think we don't really know for sure, although I think November, December infections, it probably wasn't, but we don't really know that for sure yet. In patients who had documented flu A and flu B, we used to think, as we recently as 3 or 4 weeks ago, that meant that you didn't have COVID. If we did a test in the office and you had flu A or flu B, you didn't have COVID. We now understand that you can have both at the same time, and so we just don't know. There's no question that the pace of this infection is different than flu. So COVID now, when you get symptoms, they last longer, and you can get sick later in those first 5, 7, 9 days, 12 days of symptoms, right? So in flu, it's really typically 7 days of fever, and you really peak at 3 or 4 days in terms of your symptomatology and get better. That's not exactly the course with COVID. And you are correct that this is really a pulmonary condition, that you're really getting inflammatory disease in your lungs. And again, in those percentage of people, that goes on to develop the ARDS that requires the ventilator support. If you are infected, how long can it take before it turns serious? I've had a 101 fever for the past 3 days with fatigue. I have not been tested. So I can tell you this, which is, it sounds like presumptively you have COVID. And I don't know if you have tried to be tested, and I don't know if you are short of breath or how sick you really are. I hope you've been talking to your doctor. We would certainly want to hear from you if you were a patient in our practice with fever for several days, because we would want to be checking on you. So here's the story, which is, we do know, as I just said, that it can be later. So 3 days of a fever with influenza, I would tell you that you probably were about to turn the corner and do better. With COVID, I can't be sure of that at all. Now, again, having fever for 3 days does not mean that I think you're going to necessarily be in the group of people that needs to be hospitalized and is sick, but I would be watching you very closely. And what you should really be paying attention to is, and I don't know if you have availability to have a pulse ox, but that would be one of the things that we're looking at, is how your oxygen level is and how you're doing. So I would encourage you, if you're that sick, to talk to your physician. All right. Sorry, changed COVID to covered. Okay, great. And anything else today? Well, everyone, thank you again for joining today. If there's no other questions, I hope everybody has a fabulous weekend. I'm really hoping that next week or the week after there's some data about some availability of the antibody testing. So please tune back next week, Monday at 3 o'clock. And I hope everybody continues to social distance and has a great weekend. Thanks.